Gout is a form of inflammatory arthritis that's caused by the deposition of monosodium urate crystals. It's a chronic disease that typically presents as an acute painful flare at the first metatarsophalangeal joint, midfoot, Achilles tendon, or knee that's followed by an asymptomatic intercritical period. When it's uncontrolled, flares become more frequent and start to affect multiple joints at once. They can also lead to nodules called tophi, which contribute to chronic joint pain and damage. Considering these outcomes, clinicians must know how to help patients keep their gout under control. In this video, I'm going to outline the pathophysiology, etiologies, and management of gout, putting an emphasis on diet. Monosodium urate crystals are small, needle-like solids. They're produced from the crystallization of uric acid, which is a byproduct of purine metabolism. In short, purines like adenine and guanine make up components of cells like DNA, RNA, and ATP. As they're consumed through processes like cell turnover and energy metabolism, or if supply in the body is greater than demand, they undergo degradation in preparation for excretion. The endpoint of the degradation pathway is uric acid, and it gets excreted through the kidneys, intestines, and liver. Under normal circumstances, having some uric acid circulating in the blood isn't problematic. In fact, it's actually useful because it serves as an antioxidant and as part of the innate immune system. However, when uric acid accumulates to a level of 6.8 milligrams per deciliter or above, it's called hyperuricemia, and this is where the risk of crystallization increases. While some patients with hyperuricemia remain asymptomatic, others go on to experience a flare when monosodium urate crystal deposition in a joint triggers an inflammatory response. The result is a painful, swollen joint that without treatment can persist for up to 2 weeks. Concentration of uric acid is the most impactful factor for crystallization to occur. In other words, the higher the uric acid climbs, the more likely it is that monosodium urate crystals will form. Other factors that have been identified are temperature and pH, with a cooler, basic environment being more favorable to crystal formation. A cooler temperature may explain why joints that are most distal to the heart are highly affected. Now that I've explained how hyperuricemia sets the stage for the deposition of monosodium urate crystals, I want to answer the following question. If uric acid production is a normal process, but hyperuricemia is pathologic, then how does hyperuricemia develop? The etiologies of hyperuricemia can be classified into 3 types that are usually overlapping. There's renal underexcretion, extrarenal underexcretion, and overproduction. Then within each type, there are a few different causes. Renal underexcretion is the largest contributor to hyperuricemia. The kidneys are the primary site for uric acid excretion, handling approximately 2/3 of the load. Uric acid gets filtered by the glomerulus, then there's secretion and reabsorption of it through cells in the proximal convoluted tubule, which is accomplished by various transporters. Genetic variants of those transporters are common, and they can reduce the amount that's secreted or increase the amount that's reabsorbed. So, genetic predisposition plays a major role. Other contributors to this type are chronic kidney disease, or any condition that leads to impaired glomerular filtration, a reliance on loop or thiazide diuretics, or excessive alcohol intake. Both lead to less uric acid excreted in the urine and more retained in the blood due to changes in transporter activity. Low fluid intake belongs here too. Dehydration increases the concentration of uric acid in the blood and reduces the renal excretion of it. Extrarenal underexcretion is the second largest contributor to hyperuricemia. Whereas the kidneys are responsible for the excretion of approximately 2/3 of the uric acid, the intestines are responsible for most of the remaining 1/3. A small amount is excreted by the liver through bile, but it's not significant. Similar to the kidneys, underexcretion by the intestines can be attributed to the dysfunction of a transporter from a genetic variant. There's also an ongoing investigation into gut dysbiosis, looking specifically at the impact of microbial diversity on uric acid metabolism, cell membrane transporter function, and the inflammatory response to monosodium urate crystal deposition. However, no definitive statements can be made at this time. In theory, any disease that damages intestinal cells or leads to unfavorable changes to the gut microbiota could affect the uric acid concentration. Finally, compared to renal underexcretion and extrarenal underexcretion, overproduction of uric acid contributes to hyperuricemia the least. Etiologies for this type can be broken down into endogenous and exogenous subtypes. Under the endogenous subtype, there's rapid cell turnover from cancer, blood disorders, chemotherapy, or tissue damage. After all, massive cell destruction leads to an influx of purines from components of the cell like DNA and RNA. Also within this subtype is obesity, which may be attributed to an increase in total body surface area, and inborn errors of purine metabolism, like Lesch-Nyhan syndrome, that result in excessive uric acid production. Under the exogenous subtype, there's just diet. While some foods and beverages are high in purines, others lead to the indirect production of them. Ingesting high amounts can contribute to an imbalance of supply and demand. In the upcoming sections, we're going to dive into factors surrounding the diet and uric acid production in the body, and the role of medical nutrition therapy in the management of gout. But first, I want to take a step back to reinforce how these etiologies are often overlapping. Rather than entirely being caused by genetic predisposition or obesity or thiazide diuretics, hyperuricemia and gout is most likely to occur when more than one precipitating factor is present. I also want to point out all of the different places where diet and lifestyle can play a role. Outside of individual food and beverage choices that lead to the overproduction of uric acid, etiologies like certain types of cancer, obesity, chronic kidney disease, gut dysbiosis, and some intestinal diseases are often rooted in an undesirable diet pattern, a sedentary lifestyle, and poor lifestyle choices like smoking. Therefore, when we take in the big picture of what drives hyperuricemia and gout, diet and lifestyle behaviors shouldn't be overlooked. If you're enjoying this video so far, make sure you hit the like button and subscribe to the channel. You can also get access to a written companion piece for this video by clicking the link in the video description. The companion piece is a PDF that reads like a textbook chapter, features a list of key points, and contains a list of references with links to all of the articles and books that were used. At this stage, I've outlined the pathophysiology and etiologies of gout. Now I'm going to focus on how diet affects uric acid production. After that, I'll discuss the management of gout and provide nutrition recommendations that can be applied to practice. The major dietary sources of purines are beef, pork, poultry, seafood, and alcoholic beverages. Individual selections from these groups that are particularly high include organ meats like beef and pork liver, soups, sauces, and gravies made from meat, shellfish like scallops and mussels, sardines and anchovies, tuna and cod, and beer. Foods and beverages that are low in purines include other animal-based foods like eggs and dairy products, and most plant-based foods like fruits, vegetables, grains, nuts and seeds, and beverages like water, coffee, and tea. The only group of plant-based foods with moderate to high purine content is legumes like beans, lentils, and soybean-based foods, and yet these tend to be lower than most of the major sources. In addition to foods and beverages, dietary supplements can contain purines. Examples of supplements that have been found to be high in purines are brewer's yeast, chlorella, spirulina, and DNA and RNA. Despite all of these examples, I'd say there's limited data available for the purine content of foods, beverages, and dietary supplements. Alcohol is one source of purines that requires closer examination. This is because the metabolism of alcohol may promote purine degradation in the body. Alcohol metabolism begins with the oxidation of ethanol to acetaldehyde. Then acetaldehyde is oxidized to acetate, which is converted to acetyl-CoA on its way to becoming carbon dioxide and water. The conversion of acetate to acetyl-CoA requires ATP, which is converted to AMP. That AMP is either resynthesized to ATP, or it enters the purine degradation pathway and can eventually become uric acid. Alcohol may also lead to a reduction in the renal excretion of uric acid. This change appears to be related to an alcohol-induced increase in the blood concentration of lactic acid. Possible effects of lactic acid on uric acid metabolism include competing with uric acid for the transporters that are responsible for the removal of uric acid from the blood, enhancing the activity of the transporter responsible for reabsorbing uric acid, or doing a combination of both. As mentioned previously, beer has been shown to have the highest concentration of purines, but these mechanisms suggest that excessive intake of any alcoholic beverage is a concern. Moving beyond the food sources of purines and alcohol, a third dietary factor that requires close examination is fructose. Unlike alcoholic beverages, which are a source of purines, fructose doesn't contain any on its own. Nevertheless, just like alcohol, the metabolism of fructose may contribute to the purine degradation pathway, and as a result, add to uric acid production. Fructose metabolism occurs primarily in the liver. In the first step, fructose is phosphorylated to fructose 1-phosphate by the enzyme fructokinase. Fructose 1-phosphate then undergoes further transformation, ultimately entering glycolysis to serve as an immediate source of energy, or it's used for the synthesis of glycogen or triglycerides. The phosphorylation of fructose to fructose 1-phosphate connects to purine metabolism because it requires ATP. The reduction of ATP to ADP, and then ADP to AMP, once again provides substrate for the purine degradation pathway. Thus, in theory, a high intake of fructose can lead to an increased production of uric acid. Looking into the literature on this topic, I found two relevant publications. The first one is a 2016 systematic review and meta-analysis by Jamnik et al. It included two large prospective cohort studies that investigated the relationship between fructose intake and incident gout or hyperuricemia. Using data from over 125,000 participants and 1,500 cases of incident gout over an average of 17 years of follow-up, they found that fructose consumption was positively associated with an increased risk of developing gout. The second publication is also a systematic review and meta-analysis, but it was published in 2020 by Ibrahimpour Kujan et al. Using data from cohort, case control, and cross-sectional studies, they focused on total fructose intake, as well as the intake of sugar-sweetened beverages, which are a major source of fructose globally. They found a significant positive association between sugar-sweetened beverage consumption and the risk of gout and hyperuricemia. Despite the limitations in the total number of studies available and the study designs, high fructose intake appears to be problematic when considering diet and gout. That brings us to the final section of the video, which focuses on the management of gout. The information in this section will come primarily from the 2020 American College of Rheumatology Guideline for the Management of Gout. Recommendations in this paper were produced by a core team, an expert panel, and a voting panel that consisted of rheumatologists, other clinicians, and a patient representative. They set out to answer 57 questions on the topic. 5 of them were about lifestyle factors. The remainder were about medications. Simply put, the management of gout is centered around uric acid lowering therapy. When hyperuricemia is resolved, existing monosodium urate crystals in the body can dissolve, and the risk of new crystals forming and depositing in the joints decreases. The American College of Rheumatology recommends a target uric acid concentration of less than 6 milligrams per deciliter. To achieve and maintain this level, the cornerstone of treatment is uric acid lowering medication that either limits the production of uric acid or increases the excretion of it. Diet and lifestyle interventions are far less effective, but a combination of both drug therapy and medical nutrition therapy is widely regarded as an important aspect of patient care. According to the American College of Rheumatology, recommendations for the management of lifestyle factors in patients with gout include limiting the intake of alcohol, purines, and high fructose corn syrup, losing weight if the patient is overweight or obese, and avoiding vitamin C supplementation. All of these are conditional recommendations. This means that they reflect scenarios for which the benefits and risks may be more closely balanced and/or only low certainty of evidence or no data are available. I don't have much to say about the recommendations for purine intake and alcohol intake, but I'll go ahead and I'll comment on the others. First, I wish they took a more comprehensive approach to the third recommendation by replacing the word high fructose corn syrup with added sugars. High fructose corn syrup is found in various highly processed foods and sugar-sweetened beverages that should be avoided. Still, the proportion of fructose and glucose in the syrup that's commonly used is actually quite similar to sucrose, which is table sugar. To encourage patients to avoid high fructose corn syrup and be silent on sucrose as a source of fructose seems like a bit of a blunder on their part. By using added sugars, they would cover both ingredients while still avoiding the vilification of healthful foods that contain fructose, like fruits and vegetables. Second, I wish they would have provided a little context in their recommendation for weight loss. I understand that in this type of document there's limited space to explain the recommendations, but a blanket recommendation like this perpetuates weight stigma. It's what leads to clinicians recommending weight loss based on body mass index with limited additional information. I would prefer to see the recommendation have a condition added to it, like when weight loss is realistic and achievable, since it won't be for every patient who meets the criteria. Third, I agree with the recommendation against supplementing with vitamin C, but because it wasn't mentioned anywhere else in the video, I wanted to provide an explanation. Vitamin C has been proposed as a potential uric acid lowering therapy by inhibiting uric acid production or enhancing the renal excretion of it. There's a 2021 meta-analysis of 16 randomized controlled trials that shows vitamin C supplementation can contribute to reductions in uric acid. However, the studies mostly featured participants without hyperuricemia or gout, and despite reaching statistical significance, the effect across all studies wasn't clinically significant. The only randomized control trial in patients with gout that I've seen is a 2013 study by Stamp et al. The authors found that supplementation with 500 milligrams per day for 8 weeks produced no clinically significant reduction in uric acid concentration. They concluded that the data didn't support the use of vitamin C supplementation in patients with gout. A higher dose may have a more meaningful effect, but that has yet to be determined. Other individual foods and supplements that appear in the literature as candidates for regular use or supplementation include cherries, tart cherry juice, dairy, coffee, tea, caffeine, and omega-3 fatty acids. None of these foods or supplements are addressed in the recommendations from the 2020 American College of Rheumatology Guideline for the Management of Gout. I'm not willing to totally discount any of them, though I don't feel there's sufficient data to recommend them to patients. In summary, when providing nutrition recommendations to patients with gout, we can encourage them to 1. Limit high purine foods, 2. Limit alcohol, 3. Limit added sugars, 4. Strive for weight loss if overweight or obese and weight loss is realistic and achievable, and 5. Stay hydrated. No recommendations for supplements can be made at this time. Last but not least, we should emphasize that medication is the cornerstone of uric acid lowering therapy, and that diet is only an adjunctive therapy in the long-term management of the disease. Thank you for watching. Please share your thoughts down in the comments section, and go check out my playlist on gastrointestinal diseases by clicking the image on your screen.